Hi everyone. So today I'll be presenting on our work on a multi-reader, multi-case human observer study to evaluate a deep learning-based transmissionless attenuation compensation method, namely CTLESS, for myocardial perfusion SPECT. This work was done by Zitong Yu, a previous member in our lab, and I will be presenting on his behalf. So myocardial perfusion SPECT is an established, well-validated, and cost-effective procedure for diagnosis and evaluation of coronary artery disease. Now, attenuation of photons is a major image-degrading effect that adversely impacts image quality in SPECT. However, from previous studies, we know that attenuation compensation, in short AC, is beneficial for visual interpretation and serves as a prerequisite for quantification tasks in SPECT. Traditional AC methods require a separate CT scan. However, many SPECT systems do not have CT imaging capability. In fact, approximately 74% of SPECT scans are performed without AC worldwide. And AC with a separate scan also has its own disadvantages, including an increase in radiation dose given to the patient, an increase in operational costs, and a possibility of misalignment between the SPECT and CT scans. So there's a need for a transmissionless AC method, which conducts AC using SPECT emission data only. Now, towards this need, we developed CTLESS, a physics and deep learning-based transmissionless attenuation compensation method, where we first obtained the photo peak energies and scatter energy window projections, and then reconstructed them using the ordered subset expectation maximization method to obtain an initial estimate of the attenuation map, which we segmented using a segmentation network and then assigned predefined attenuation coefficients to obtain a final estimate of the attenuation map, which was used for attenuation compensation of the photo peak energy window projection to obtain the final activity reconstruction. Now, the clinical translation of CTLESS method requires it being evaluated on relevant clinical tasks. In MPI SPECT, this clinical task would be detecting cardiac defects. So CTLESS was evaluated on the defect detection task with model observers and was also compared with a standard CT-based AC method, namely the CTAC method, and a no AC method, namely the NAC method. And our model observer studies showed that CTLESS was statistically non-inferior to CTAC. So the promising performance of CTLESS that was observed in the model observer studies motivated its further evaluation using human observer studies. So we evaluated CTLESS on the defect detection task in a multi-reader, multi-case, in short MRMC, human observer study with expert readers. So this was the MRMC study design. Now First, the study was done with a cohort of normal perfusion MPI SPECT stress images with inserted synthetic defects as a ground truth. In the study, we had a total of 12 expert readers, including 8 physicians and 4 non-physician readers, who all went through a rigorous training session where they were introduced to the defect detection task and possible defect types. They then practiced on 20 patient examples with a corresponding ground truth. They were then introduced to the web-based interface that they would be using, and then practiced another 30 examples on this interface. And then we monitored the AUC values, their use of rating scale, and the demarcation of defect locations. So we also conducted a power analysis from a pilot study of 100 patients to determine the number of patients that we need and the number of readers and number of reading groups that we need. And from that, we determined that we would need a number of 240 patients and a number of 12 readers split into 3 reading groups. Each reading group has 4 readers, and each reader would read 4 sessions each. And from that, we analyzed the reading results using the IMRMC software to obtain the ROC curve, the AUC averaging over readers, and the non-inferiority test. So here are the results of our ROC curves and the AUC values. So as you can see on the figure on the left, the ROC curve obtained by CTLESS almost overlapped that obtained by the CTAC method. And on the figure on the right, we can see that the AUC obtained by CTLESS was similar to CTAC and had significantly outperformed NAC. Now, to assess if CTLESS has potential to perform as well as CTAC in clinical settings, we conducted the non-inferiority test. The purple shadows there are the 5% margin of the CTAC obtained AUC. And as you can see, the horizontal black lines are the confidence intervals of each method. And as you can see, the lower bound of the CTLESS confidence interval is within the margin of the CTAC obtained AUC. So from this, we observed that the performance of CTLESS was statistically non-inferior to CTAC within a margin of 5% of CTAC obtained AUC. We also conducted stratified analysis on different sexes and saw that the AUC values obtained by CTLESS was similar to CTAC. And similarly, a stratified analysis across different severities and extents had a similar result of AUC values as well. And lastly, to determine the ability of CTLESS to replace CTAC at the individual patient level, we conducted an interchangeability study. So as you can imagine, in the human observer study, when two readers are looking at the same images from the same patient generated by the same method, they may still come to different conclusions on the defect presence. So we calculated this disagreement rate between the CTAC method and then also replaced one CTAC method with the CTLESS method, and then calculated the disagreement rate. So here we define the percentage increase in disagreement of less than 5% to be interchangeable. And as you can see, the percentage increase in disagreement of CTLESS to CTAC is less than 5%. So we observed that CTLESS is interchangeable with CTAC at the individual patient level for the defect detection task. In conclusion, the CTLESS method yielded a non-inferior performance to CTAC on the cardiac defect detection task as evaluated in a multi-reader, multi-case human observer study with 12 expert readers, which supports potential for clinical translation. That's it for my talk. I would like to thank all lab members and collaborators who have helped us.
7 minutes, 13, something. So you don't have